So, welcome again to another episode of School of Airway. There's a concept that I think is going to eventually happen. It already happened in ATLS, where we had airway, breathing, circulation, and D changed in order for priority of circulation. So, I do think that what we learned in the military and what we learn in other aspects in medicine, we should combine some ideas to provide better care. So, for the instance of changing the priority of airway to second place and emphasizing on circulation of doing CPR, great idea. The heart's not working, providing all the air in the world to the lungs that aren't even moving because no heart, no movement, and there's no circulation going on, no spontaneous circulation is occurring. Makes sense, right? So, does it matter if you intubate someone who is exsanguinating to death? Does it make sense that we to control the airway first? I don't think so. Thanos, one of my former Greek fellows, good friend, brought many good ideas to me. Emphasized that circulation is probably the most important thing you should emphasize. Talking to the patient, make sure they're perfusing their brain right. Now that won't explain if they're intoxicated, but if they're coherently thinking, there must be enough perfusion from the blood pressure, even before feeling a pulse, that they're awake. Of course, they're always in a coffin position, which makes no sense. And if they don't have a broken back, you sit them up. And if they do have a suspected broken back, maybe do some reverse Trendelenburg, right? So the issues about hemorrhage. If there's a hole in the groin, hole in the neck, hole in the axilla, small wad of gauze, direct pressure. Or if there's a huge laceration, direct pressure. If the patient needs a tourniquet, borrow one from the paramedics or buy one yourself. Okay? From your shop. Your shop should have tourniquets. If not, manual blood pressure cuffs. Okay? Stop the hemorrhage. Pack the excessive bleeding. Okay? Airway, talk to your patient. If he's aspirating or actively vomiting, control the airway. If he's spontaneously ventilating and oxygenating on his own, you can get a baseline ABG to prove that. ISTAT. Okay? If the blood pressure is getting tenuous when you first saw him, you may have to intubate him because you don't want hypertension to cause another injury to major organs like the kidneys, the liver, the gut, the brain, the heart. So, if you can't tube them because there's too much fluid and blood, LMA or King LT. Try to provide one with a gastric port. Suction as much as possible. Maybe do gastric diversion, a term and a theory and an idea that I've borrowed from James DeCanto of like salad, suction assisted laryngoscopy assisted decontamination, airway decontamination. Gastric diversion sounds a little bit simpler to me. Goose the patient on purpose, connect that to the wall suction as much as possible. Divert the tube away from your blade and tube them directly into the trachea without worry of active aspiration happening. Control the airway as much as possible. Alright. I would recommend video laryngoscopy the best. But remember, VL blade doesn't work, DL blade technique usually works. If the DL technique doesn't work, the VL blade technique works. It's usually the experience of the person who's the airway operator. Okay? Alright. B. Right? Patient's either chatty, cursing, anxious, or calm. Right? You control how much breathing this patient is doing. If you've already given the medicines for RSI, right? Choose appropriately. Don't give Versed or midazolam. Consider etomidate. It may drop the blood pressure a little bit. That's a myth that the blood pressure doesn't drop with etomidate. With ketamine, the blood pressure won't drop. It will go up. If you're going to give it a quick push, it's going to work fast. He will get apneic, but he's also going to get apneic if you paralyze him. So in this scenario, it's not harmful to give sucks. It does last the shortest of the paralytics, but he's going to make sure he had fresh injuries, fresh crush injury, fresh burnt injuries, burn injuries, the potassium won't, and CPK won't be that high. Not yet. It will happen later on. But immediately within hours of the golden hour of the injury, something not to worry about. But guess what? Why do I need to sweat it? Why do I need to worry about this potassium? Why do I need to worry about if it's baseline creatinine? Give rock instead. Only issue is neurosurgeons may want to do repeat exams, and there's no good reversal agent for rock, except for in Europe and just coming to the United States, Sugammadex. Very expensive. Very expensive. It may be at least $500 for all the vials that you give for a person to reverse it within a few minutes. The rock that you gave, that may last 45 to an hour and a half of paralysis. Alright? Despite the CAT scan that shows the herniation or left shift of the brain from a subdural or epidural, that requires an intubation because of patient's deterioration in GCS. But some people want to reassess the patient after he comes from CAT scan and shows, and if I can't evaluate him because he's paralyzed, that will delay his surgical care. It's an issue that people ignore and don't want to mention in ATLS. Okay? See? Go back. That's how important this is. So this is not like CABCDE and ACLS. I believe circulation is such an important thing in trauma. It should be CABC, then DE. Right? So again, reassesses blood pressure after either tourniquets, packing, direct pressure. If you can, now's the time to go zoom, zoom. Easy IO. Some people have the gun version of the IO. Put it in appropriately, hopefully correctly. You can throw a central line, it takes a lot longer. IOs work in the humerus. Within 3 seconds, it goes to the heart. Pretty good access. Surgeons are slowly getting on board with IOs. I know the military's embraced them. Central line takes a lot longer. You may have to pop an ultrasound on the arms or limbs to get a line in, because for peripheral access, if the patient's clamping down from vasoconstriction from shock, right? Or a patient maybe just bad anatomy, a sickle cell patient, a chemotherapy patient, a patient who's morbidly obese, a patient who does IV drug use, maybe hard to get a line, may need to use ultrasound, not just for the fast, but to get access. All right? If he's truly in shock, you may have to expedite the secondary serial ultrasound and say, hey, what can I do to save this patient's life? Does he have a pneumothorax? Does he have a hemoperitoneum? Does he have pericardial tamponade? Hey, you could diagnose that with an ultrasound. Just look at the base of the lungs when you do the Morrison's patch of splenorenal recess. Aim high, aim at the lungs, at the diaphragm, you will see collections of fluid. More likely to get a higher yield and keeping them in reverse Schindellenberg for those images. Okay? And then we want to look at the belly, like lamb flat, to get positive fluid in Morrison's pouch. Now looking at the base of the diaphragm, you could do some Trendelenburg. Look at the recesses, the renal recess. Look at the hepatorenal recess of Morrison's pouch. You will get a higher yield just tilting the bed slightly in Trendelenburg. And you may want to tilt them down again to see fluid around the pelvis, around the bladder. All right? I do think there may be a role of looking at the IVC. Sometimes the tachycardia could be from pain, anxiety, stress, drugs, or from hemorrhagic shock. It'd be nice for a younger patient to look at their IVC to see if it's collapsed, or collapsing completely, or fully distended. If it's fully distended, they have shock. They have some obstructive shock. No? Young person who's healthy, got stab wounds to the chest. That's a pneumothorax somewhere. That's a pericardial tamponade somewhere. I doubt they developed an acute CHF failure, heart failure, or acute MI, or acute PE causing his shock-like state. Remember, recent trauma, look for the, do a blood sweep, head to toe, look for the wounds, cover the parts of the body that need to stay warm, okay? Look for, signs of hemorrhage. Get red stuff in them. Please try your best to avoid diluting the blood. Avoid making Kool-Aid out of the blood that has enough coagulating factors, enough platelets, enough PRBCs to provide circulation, perfusion of the end organs. All right? All you do by adding normal saline or LR is making it Kool-Aid. Right? Kool-Aid are not that bad when it's as instructions, following instructions. Sweet, artificial, I get it. You dilute it out because more kids came to the party that were invited. Does not look like Kool-Aid. It just looks like water with red stuff in it. Same thing, the body treats that liquid that you're treating. Diluted blood doesn't do well. Lactic acidosis, coagulopathy is going to increase. If you don't warm up that fluid that you gave, regardless if it's red or white or clear, they're going to get cold. And that's going to promote the lethal triad. Hypothermia, coagulopathy, acidosis. Okay? D, patient either admits it or we suspect drug use by paraphernalia, or they admit it to using drugs or drinking alcohol, or the smells. Remember, the agitation could be from the head trauma, or there's a jerk factor. All these 4 factors can lead to the GCS you calculate. All right? You may not like it that he almost kicked you in your face, but that's a nice score for his motor. All right? Eyes open, yelling at you. Hey, he may be disoriented or confused. Maybe his GCS is 13, but it's not 15, not 14, but 13. You know, it's up to the persons in the trauma rooms, tolerance of a combative behavior, right? Because if he's combative to himself and combative to others, we may not be able to help the patient, who may be severely injured. Okay. Environment. Keep the room hot. I do think that when we do the Wolverine on every patient, regardless if it's a trauma alpha, level 1, level 2, or level 3 trauma, exposure is important. Hey, some of these patients go home. Sometimes they have a bad mechanism. The car is injured way more than the patient. So, hey, perhaps we unclip the belt, unbutton the blouse, remove the clothes quickly, look for injuries. Then they have clothes to put on when they can leave the hospital. Plus, when you do truly clean, take off all the clothes, and it just came out of a cold environment outside, they're going to be freezing, shivering, right? And we don't always have enough warm blankets in the heater, okay? We don't always give warm fluids. Even KVO we don't give all the time, okay? So, patient's not happy when they're cold. It's hard to find veins when they're cold, okay? So, in the military, I think, the Nazis told me that you're cutting enough to look for blood, doing a blood sweep, look for the injuries, deformities, like ecchymosis. But guess what? If you have enough blankets to cover them up, great. Cover them up as soon as possible as you expose them. Because what usually happens, they're butt naked, getting cold and ill. Okay? That's your E part. B, call the OR if they need to go to the operating room. And again, you do it again. CABCDE. I think circulation should be done twice, but just my opinion. You know, emphasis on tourniquets and unpacking. If you have packing that promotes coagulation, like a quick clot or hemcon, even better. Tourniquets are essential. The CAT device is very easy. Paramedics have been using it. I think we should be using it. All right. It'll be worse if the patient has blunt and penetrating trauma. If there is penetrating blunt trauma, and you suspect, along with the first one, he could hemorrhage in his pelvis if he has a rocky pelvis. Wrap the pelvis sooner than later. Don't do, if you have to do it ghetto or poor man style, use your sheets. But if you can, get a binder. Makes it easier for everyone. Okay, and put it on appropriately. All right. So again, CABC. Get your IVs in as fast as possible. Once one side is done, you could start doing an ultrasound if the patient truly is in shock. I do think the IVC has a role. All right. It gets a little bit more complicated when the IVC is collapsed, because there is true hemorrhagic shock. And you can have complete IVC collapse with true hemorrhagic shock. Blood on the field, blood on the street, blood in the limb, even if the patient has obstructive shock. You better hope the patient still has a pulse, even if thoracotomy. All right. D, if once he's intubated, sedated and paralyzed, it's kind of hard to get a D out of this. Make sure you looked at the eyes before you intubated him. Okay? Was the anisocoria, where the pupils dilated or pinpoint before you committed to paralyzing and sedating this patient. Unless your neurological exam becomes accurate after the neurological paralysis wears off, and you can find focality on the exam. Patient could probably withdrawal or localize the pain. And again, E, Get your stuff ready. Despite people passing ATLS, they don't even understand ATLS. That's a fact. As an ATLS instructor, we need to do better. Teach better, learn better. Okay? One other thing. TEG is coming. Probably going to replace our coagulation profiles in the near future. Rule out inherent coagulopathies the patients have, or bleeding dyscrasias, or what dyscrasias they have, bleeding disorders because of medications they take. Aspirin Plavix and the NOACs, the Naval oral anticoagulants, or old school warfarin, or old school Lovenox and heparin. Okay, so I know I said a lot of things, but CABCDE, in my opinion, should probably be the way we do trauma. Bye Thanasis of Greece. Ciao.